Great. Thanks so much, Steve. And thank you to all the presenters that are joining us today and for all the attendees. So I'll just go over a few slides here, which is an introduction to COVID End. And in particular, one of the 7 working groups, the engaging working group that were responsible for the webinar series. And sorry, just as So for those of you that aren't familiar, COVID End really was developed as a time-limited network that came together in response to the COVID-19 pandemic to help those who were supporting decision makers to find and use the best available scientific evidence to support decision making. And a second objective was really to help avoid waste by reducing duplication in evidence syntheses and trying to work together internationally to coordinate evidence syntheses and dissemination. The partnership grew to more than 50 organizations around the world who volunteered to become a part of this collaborative and to really share methods, share lessons learned, and really work together to help support decision-making around the world. And it covers the full spectrum of the pandemic response, from public health measures, clinical management, health systems arrangement, and economic and social responses, as well as the perspectives of high income and low and middle income countries. Just a quick snapshot here of the logos of many of the partners that have participated in COVID End. And then there's a variety of ways to learn more about COVID End. Of course, you can visit the website, where there is a tremendous amount of information on the website that is categorized for decision makers and researchers. So different types of resources that are there. There's an inventory of best evidence syntheses for the 4 key areas of public health measures, clinical management, health systems arrangements, and the economic and social responses. And this is where an incredible amount of work has gone into finding all of the syntheses that have been done in these areas and appraising them and compiling the best of those into this inventory. Of course, the whole database, if it isn't already, soon will be available for searching. But to decrease the amount of time it takes to find the best available evidence on pressing questions in these areas, the inventory is available. There's also been a horizon scan for emerging issues. And then a community that was developed. There was an online COVID End community listserv that was created that actually has over 350 members now, where key topics and lessons learned are shared. And the link to that, it's still accessible for people to join up. The monthly webinar series, as well as a living hub of hubs. And then you can also find out more by emailing covidend@mcmaster.ca, as well as the Twitter handle is listed at the bottom. So lots of ways to learn about COVID End and to become engaged. And then just briefly around funding, COVID End was funded in a variety of ways early in the pandemic, was funded through the government of Ontario for a project that is known as RISE, that was temporarily put on hold. Then funds from that were used to support this, as well as additional funding from the National Institute of Health Research in the UK, as well as a variety of individual donors, as we can see here. And then for the past year, funded through a grant through the Canadian Institutes of Health Research in Canada. So just to get to the main topic for discussion today is really to discuss how some examples of engaging public and patient partners in rapid reviews. And as evidence synthesizers, myself and Dr. Andrea Trico will talk about our processes for doing that. And then we also have Maureen Smith, Amanda Doherty-Kirby, and Mike Scott, who will talk about from the perspective of patient and public partners. Maureen will talk about how she has supported bringing together, identifying patient partners to be involved in rapid reviews, and Amanda and Scott will give their perspectives and lessons learned as patient or public partners being involved in rapid reviews. And so just a little bit about the NCCMT, that my center, the National Collaborating Center for Methods and Tools. We aren't normally or weren't normally in the business of doing evidence syntheses to support decision-making in public health prior to COVID. We really have worked for over 12 years as an organization to help build capacity amongst the public health workforce and organizations to engage in evidence-informed decision-making. So we help them with building the knowledge, skills, and attitudes to do that work. But when COVID struck, very quickly it was determined, as most in public health, if not all, were reassigned to other activities related to the COVID response, that there was no capacity in the sector to be looking at the piles and piles of studies that were emerging and synthesizing those to inform decision making. And so we had the autonomy from our funder, the Public Health Agency of Canada, to reallocate our funds to support the COVID response in however we felt that we could best do that. And so we quickly started receiving requests from frontline public health to provide a synopsis or a listing or a synthesis of the evidence that was emerging on public health on COVID. And so we transitioned to providing this rapid evidence service based on requests from public health decision makers. And we really think of it as a relay race in terms of the distinct activity. So you can see the diagram down the right-hand side, where we learned over time that what worked well for us was to assign different staff to different pieces of the rapid review process. Once we received more questions than we could take on, so we had to develop a way to prioritize those questions. We worked from what we had already developed, a rapid review guidebook, although we've made several modifications to that for the COVID context. And from the beginning, we were completing these reviews in 4 to 5 days. Then we've transitioned to 5 to 10 days. And depending on the question now, where there's much more evidence available, it might be longer than 10 days, possibly 15, but still very rapid in terms of how quickly those are being done compared to pre-COVID times. We receive questions from all levels of decision-making: federal, provincial, territorial, local public health organizations, as well as internationally. We developed a weekly team meeting where we can assess progress on any current reviews and assess our capacity to start new ones in the following week. And then we also developed criteria for prioritization, which was primarily around avoiding duplication. So if there were reviews already completed on the topic, which we could look to see through COVID end, if anything had been identified, we would let the requester know about those and only embark on doing new syntheses if what was currently available was out of date or may not have been done in as rigorous a way as we felt was really important to do. Then we might embark on it. The question needed to be of urgency or relevance in the Canadian context. We also needed to feel we had the expertise to do it, and that there was also useful evidence available to do the synthesis. So in doing the rapid review this quickly, we also had to, there are definitely some trade-offs in terms of we can't do everything that would normally be done in a very rigorous systematic review. And so our decisions were, we absolutely did critical appraisal almost 100% of the time, but that was completed by one reviewer and verified by a second, as opposed to having 2 independent reviewers. Resolved conflicts through discussion or brought in the review lead as a third person if needed. We used a variety variety of existing appraisal tools to assess the quality of the evidence. And then we finally rate each study as strong, moderate, or low quality. At the very beginning, we did not do grade, but about 4 months into our rapid reviews, we started applying grades so that we could give an overall assessment for each statement we made in relation to the outcomes, how likely those findings were to change as more evidence emerged. And you can see here the 8 domains that are identified in terms of how you assess the certainty of that evidence. And here the evidence is rated, you can see, as very low, low, moderate, or strong. So we feel that this was a really important piece to add to the process. And then the final product looks quite a bit different from anything we would have done before in terms of your traditional type of write-up. The question is right up front on the front page in the title. We have an executive summary that's usually no more than 2 pages long that looks at the key findings identifying the grade or the certainty. If it's an update to a previous review, we also start with what has changed, a paragraph about what has changed since the previous review. And then we have a section on the overview of the evidence and any knowledge gaps. Then we provide information around our methods with links to additional documents that give more detail about the methods if needed. And then all of the data that is used for the executive summary is put in tables in the results section. And then just around the executive summary, this just gives you an example of what that looks like, a background section of no more than 1 to 2 paragraphs that again highlights the question. Those key points, there's usually 3 to 5 key themes with the grade. The overview of the evidence, again, maybe 3 to 5. And as I said, if it's an update, we have that first paragraph. And then in our most recent review, where we were very lucky to have 2 citizen partners. This was a review that was looking at COVID-19 and the risk for serious outcomes in children under 12 and what were risk factors for that. And with the information feedback that we received from our, I'll call them in this case, parent partners, we actually created a whole new section that we felt was really, really important to highlight for decision makers. So our key questions are how to meaningfully engage patient and public partners in the rapid review process when there are really tight and sometimes changing deadlines. What are the most important steps to engage and when to engage patient partners? How do we appropriately and meaningfully incorporate patient and public partners' input into the executive summary, and then what are other things we can do to ensure that public and patient partners feel supported and empowered to participate meaningfully in the review. And so I'm going to stop sharing and now just call on Dr. Andrea Trico to tell us about her process with the Evidence Spore Alliance.
Great, thank you so much, Maureen, for that excellent overview of all the hard work that you and your amazing team have been working on. I'm going to share my screen here and just make sure that this is going the way it should. And there we go. Great, excellent. So I'm incredibly excited to be here today discussing a little bit about the Spore Evidence Alliance and in particular how we engage with patient partners through our initiative as well as on rapid reviews. So for the acknowledgement of traditional land, so we are located on land now known as Toronto. So Toronto is a traditional territory of many groups, including the Mississaugas of the Credit and the Chippewa Ojibwe of the Anishinaabe nations, the Haudenosaunee, as well as the Wendat. I just want to note that the Spore Central Office is incredibly committed towards working towards reconciliation, and we strongly advocate that everyone learns, and in particular, everyone takes Indigenous cultural safety training. So in terms of conflicts of interest, I don't have any financial competing interests. Academic interest is that I love everything knowledge synthesis, incredibly passionate about this. And also I'm the NPI of the Spore Evidence Alliance. And I'm involved with many journals. I do receive a small stipend from the Journal of Clinical Epidemiology, but the rest is all free work. So just to give you a little snapshot of the strategy for patient-oriented research, or Spore Evidence Alliance. So this was made possible by a 5-year grant from the Canadian Institutes of Health Research. And we welcome everyone open arms to become a member. And in the past 4 years, we have the opportunity of welcoming more than 350 members across Canada and abroad. And what we were funded to do was to provide research services. So we try to respond to our decision makers through knowledge synthesis guidelines and knowledge translation. And people can submit or decision makers can submit their queries through our web-based form. And then what we do is we work with them to tease out exactly what they need and how can we answer this using a research question. And then we would match them up with a team. So we've been successful in having 18 teams across Canada and abroad as well to match them up with decision makers to conduct projects for them. And we use an integrated knowledge translation approach whereby we're really trying to move towards co-creation. So we invite all members of the team to work together and become equal members of the research team. And we try to tailor everything that we do according to our decision makers' needs. So our goal was to respond to 100 queries. And so we've responded to about 124 to date and counting. So we're still going on. And we've been able to engage with 194 decision makers, 180 patient partners. And then also we're really focused on capacity building. So we've also been able to engage with 95 trainees. And to say that we've provided services to 45 different decision-making organizations, provincially, nationally, and internationally. And we also have a mechanism whereby patient partners could submit their topics. And then it's something we're really excited about. And we go through a priority setting process. So it's kind of like a James Lind Alliance modified approach. And then when the topics have been selected, the patient partner who suggested the topic gets to receive proposals from researchers who submit like a little mini grant to them and say, you know, this is why we're the best team to do this project. And the patient partner selects the team. And then the patient partner is the co-lead of that project. So something, a pretty unique mechanism that we have and something we're really excited about. And so also we've been heavily involved with COVID, as Dr. Dobbins mentioned, you know, there's just a huge demand with COVID, and we've been collaborating with COVID End as well as one of the teams and one of the networks providing different types of rapid review services. And so just to give a couple examples of how we've engaged with patient partners. So we have our patient partners that are on our governance committees. And also we have, for half of our governance committees, we have a patient partner as a co-chair. We try to co-develop our policies that we use. So for example, we have 2 policies currently that we've co-developed with patient partners. And then we also have the research questions or queries submitted by patient partners. We involve our patient partners as a peer reviewers on an annual seed grant competition where we provide funding to trainees and early career researchers. So we would ask our patient partners to specifically comment on the impact of the project and how they would be engaging with patients and the public. And then also to say that we have a panel of patient partners that can be engaged with different rapid reviews, and that we developed a training program. It was actually developed by Maureen Smith, who's on the line here today, and Janet Gunderson. So we had 2 patient partners lead the whole thing. They told us researchers where we had to be when, and it was a really fantastic initiative. And they will be writing up the paper, or they've written the paper actually that we still have yet to review, and we'll be publishing a paper on that. So in terms of how do we engage patients and the public in rapid reviews, So we've developed quite a bit of guidance. Including how can we meaningfully engage patient and public partners? How can we budget for them? So how can we show our appreciation appropriately? So we co-developed an appreciation policy with patient partners. So we've been trying to provide a lot of guidance to researchers as well as our patient partners. And just to say that actually researchers need more guidance on this than the patients. The patients are amazing. It's more researchers who say, oh, I don't really know how to do this, I'm not comfortable. And I think part of it is that, this is new for many people. And just to say that, we're happy to provide support to the teams, and we're just so thrilled that people want to do this because we strongly believe in it. And it's really important to increase the impact of our research. So definitely something we're always trying to build is capacity building, and how can we train researchers to do this and do this even better. And then also we use rapid reviews, methods, guidance, resources. So we have quite a few resources on there. And I know Dr. Dobbins, you just released your new rapid review guide. It's actually on my list to read. I can't wait to read it. And I'm sure I can learn from you and all the amazing things you've done with the NCCMT and incorporate some stuff into our resources as well. In terms of some of our lessons learned, so we've been able to match, and Maureen Smith might be talking a bit more about this, but we've been able to match, I think, 22 of the 24 patient partners. And so some of the things that we've learned is that, the importance of providing training, the importance of starting early. So we don't want this to be tokenistic. We want our patient and public to be engaged from the very, very beginning. We want to make sure that they're acknowledged fairly. Always being sure to create a positive and inclusive environment, and we strongly believe in diversity, inclusivity, and making sure that we really foster a really brave space where people can speak openly, and then also trying to minimize the barriers to patient and public engagement. So quite a bit of tips and lessons learned that we're always happy to share. So just want to acknowledge our funding partners. And I think with that, I want to allow enough time for our amazing patient partners. So I think I'm going to move this to Maureen Smith next.
Okay, thanks, Andrea. And I think someone at the is going to share my slides, right?
Yes, just
you can't trust me to do that.
Just give me 1 second here.
I'll start talking. I'll start talking while you're setting it up. So hi everyone, thanks for joining us. Merci d'être ici aujourd'hui avec nous. So I'm Maureen Smith from Ottawa, and you're probably wondering, how did I end up here? So I'm a patient with a rare pediatric disease. So I call myself a frequent flyer in the healthcare system since the age of 4. And for more than 20 years, I've been involved in various Canadian and international committees and advisory boards. And I'm especially a very passionate patient partner working with research teams. So I'm a Cochrane consumer, and that's where the link with the evidence synthesis comes in. I'm actually now the chair of the Cochrane Consumer Network Executive. So I'm a user of evidence synthesis, and I'm also a promoter of patient and citizen engagement and co-production of evidence synthesis. So way back when COVID started, I heard about it on a Cochrane committee that I was sitting on with John Lavis. And if you listen to John's story, John and Jeremy, they'll say that I nudged them. That's a very polite way of saying what I actually harassed them is probably a better term. And to say, well, what about patients and citizens? Are we going to get involved in this COVID end? And so in August 2020, when they were just doing the global work, they brought me on a call, the two of them, and said, oh yeah, great, yes, we want to do this, and you're going to co-lead it. So one lesson learned is be careful what you ask for, because you may end up running it. And they paired me with Dr. François-Pierre Gauvin, who's the senior scientific lead of citizen engagement and evidence curation for the McMaster Health Forum. So that was that's an absolute dream there. So we've been working together on it. And then in 2021, we received the funding from the CIHR, and COVID in Canada arose out of that. And that was an incredible opportunity. So next slide. So COVID in Canada was just like, okay, now we can actually do something on here in Canada. So I was completely committed to engaging citizens now. So in Canada, we talk a lot about patient engagement, and in the CIHR definition of our patient-oriented research, it really is patients and caregivers, and the citizens are not really in that definition. For COVID end, we had this huge public health crisis, so we had to kind of expand to also include citizens. So that was very interesting because all of our resources are aimed at people with lived experience or with their caregivers. That was a bit of a challenge. So all of the topics are relevant to citizens, and thus engaging them was essential. So that was one reason why I was committed. And you know, they kept talking about decision makers and decision makers. Well, we are decision makers, and we were making personal decisions that had tremendous societal impacts. And then we, of course, I believe that we can help shape research, you know, to be more responsive to the needs of Canadians, you know, based on our priorities, on our outcomes that are relevant to us. And then, you know, it goes without saying that we have this unique knowledge of that can help interpret and contextualize research evidence. Next slide. Okay. So it was definitely challenging to do this for several reasons. So first of all, the whole ecosystem of evidence synthesis is complex. It's not really public friendly. Most patient partners engaged in systematic reviews, you know, are involved at the end stage as peer reviewers. But the pandemic created this incredible opportunity as not only the patients, but the general public were immersed in all this evidence. And there was this renewed interest in science. So from my perspective, as a person who champions co-production of evidence synthesis and making it accessible to patients, caregivers, and the public, you know, we definitely had to do this. And we thought that the patients and citizens should be engaged in areas where traditionally they haven't been engaged. So, you know, in the prioritization and the framing the questions and interpreting the findings, they're engaged in those areas in other research, but not often in evidence synthesis products. So that was the part that was going to be challenging. Next slide. So we did acknowledge that there were going to be all of these challenges, and François Pierre and I, you know, conduct our collaborations and approach to challenges and solutions through the lens of mutual learning. So we have this enormous respect for the challenges that the researchers are facing in conducting those rapid evidence synthesis products, and respect for engaging citizens meaningfully. And how do you take those two and put them, you know, marry them so that you end up with something that is meaningful to both. So again, in Canada, we have all these resources that are available for patient-oriented research, and we've made great strides in that, but the focus is not really on citizens. So we have to kind of think a little bit about that. And Amanda and Michael talked about some of their challenges, so from their perspective, but some of the challenges that we faced was that quick turnaround time. So, you know, and the solution to that for us was to be clear about that timeline, so people could say, well, I'm in or I'm out. So don't assume that people don't want to do it quickly. Don't make any assumptions for the public. Another one was that there's not enough time. So, you know, if we offer resources to researchers that are very time consuming, they're honestly not going to have time to look at them. So we tried to design everything that was really quick and could get them exactly what it was they were looking for, with the hopes of thinking that maybe, you know, 6 months from now, we'll look back and we'll offer more in-depth training. But at that moment, it was a crisis and everything had to be done quickly. And so we kept that in mind when we put our resources out, you know, a page or two, that was going to be good. And then about the relationships, well, we tried, François Pierre and I tried to be a bridge also between the researchers and the patients, and that would maybe help those relationships too, knowing that maybe the researcher wouldn't have as much time as they would normally have. So we just tried to find solutions that were respectful of everyone. Next slide. So our first thing was we're going to recruit this pool of people. And I can't tell you how much sleep I missed over that one. I kept thinking, what if we get all these people and researchers don't want them on their teams? You know, like, we can't really kid ourselves. I can talk to them blue in the face about engaging them. There's no mandate to do that. They're what they call nudges. Now, fortunately, people like Andrea Traco and Maureen Dobbins and her team jumped on and said, yes, we're going to do it. We had no idea if that was going to happen at all. Well, we kind of knew Andrea was going to do it because she had already committed. But as far as all the other researchers go, we really didn't know. So we put this call out, and within 10 days, we had 80 people apply. And we're like blown away, like, and you know, we made it pretty clear it's going to be quick. So fine. So we've got this pool of people. We've matched all but 2 of our pool members at this point. So we're pretty happy with that. And then we've assisted other groups like the Public Health Agency of Canada, contacted us. We recruited people for them. We just had a group from Queen's University in Belfast, and we've got 3 of our pool members who joined that team now, doing international work. And then we try to develop some resources globally for the COVID and global group. And of course, we provided training for our partners. Our partners, I think that was probably really helpful too. Next slide. So from day one, COVID-N's been collaborating with the Spore Evidence Alliance so that we're not duplicating our efforts and to expand our networks. So they very kindly invited our citizen pool members to the course that was co-designed. And the Spore Evidence Alliance has more of a focus on patient partners, and the COVID-N has more of a focus on citizen partners. So put that together, that was a good combination, and we trained 24 people in a 10-hour mini course, then we let all the researchers know we've got all these people who are trained and ready to go, and I think that probably helped out a lot also. Next slide. So we try to do very practical things for the researchers. So we came up with this request form. So it was kind of telling them, okay, think about what you'd like to do. Here are some options, you know, and get all this information down so that when we approach our citizen and patient partners, we can give them as much information as possible so that they can make a decision about whether to, you know, jump in with your team or not. So it served both groups. So again, that you know, what I was talking about, how François Pat approached our work was through, you know, a lens of mutual learning. So here's some learning for the researchers. This is kind of what you have to think about before you invite people to your team. Here's some learning for the citizen partners. This is what you should be thinking about before you accept. And so that seems to have worked well. We haven't had any negative comments about that. And people, we just, it's not an option. We just send it to everyone. They use it, they fill it out, and it goes on like that. And that's an example of something really quickly that's done really quickly, but seems to be effective and is not adding a lot of work to our researchers. Last slide. And then Andrea talked about an appreciation policy. So we just thought the one from the Spore Evidence Alliance was very well done. So we use that appreciation policy, and we do compensate our citizen and patient partners. So I'll stop there because I want to make sure that Amanda and Mike have time to tell you about how it all worked out practically. That was the plan. Thanks a lot.
Thanks so much, Maureen. And now we'll pass it over to you, Amanda. Go ahead.
Okay, so my name is Amanda Doherty Kirby, and I'm zooming in from Prince Edward Island in the unceded and traditional territory of the Mi'kmaq. And I just wanted to share my experience today with a rapid review. And I'm showing that as funneling relevant articles into a finished review here. So I've made some very simple slides to share with you all. And I'll say the first thing was making connections, and Maureen is right. Actually, I only became aware of engagement research in the summer of 2020, and I ended up taking a family engagement and research course in the fall of 2020, and somebody from my connections there mentioned the SPORE, and I'm like, okay, what's the SPORE? Then I looked at a newsletter, saw the code for COVID-N, and said, I was really frustrated at the time. I kept seeing lots of things online with misinformation and evidence that didn't make sense. They're saying such and such doesn't work. And I'm like, well, there's a difference between things not working and there's no evidence support something working. And also I have a lot of lived experience that I'm going to talk about in a couple of minutes and share with you as to why I wanted to be part of COVID-N. But I wanted to use that lived experience and my frustration with the misinformation that was going around to make a difference. And I think COVID-N is helping for us to do that as citizen partners. I was pleased when they offered training, because the first initial training was a meeting, but also a view, a small video on what evidence synthesis was, which I was really appreciative of. But the training that was offered through the SPORE Evidence Alliance was enough to delve into some of the picky points about rapid synthesis, and also give me confidence to be able to participate as a engaged citizen. So Maureen talked a little bit about the citizen engagement form that was made. It's a kind of a work smarter, not harder tool, something that can be easily filled out without taking much time, but give enough information, as Maureen has said, to make a decision as to whether or not you want to partner, and also give a opportunity for the researcher to really think through where they want citizens to partner. And so in this case, with the pool, we have a topic of the review. We have our pool and then a match. And I really don't know how I would have gotten connected without a pool, especially for something that takes such a short period of time. I'm really appreciative. And because the pool is diverse, then there's all kinds of different viewpoints that can be accessed as citizen members for rapid reviews. So the first review, and really at this point, the only one, although I've just been added to another team, that I was able to participate in, the first thing that happened after I agreed to the review, after receiving this engagement form and saying, yes, I really want to do it, was being introduced to the researcher. And we set up a virtual meeting, and where I shared my lived experience and also my experience with rapid reviews. Well, I'm a parent of 6 children. They range anywhere from age 8 to 21. So I have a young school age child in grade 3, and I have a second-year university student. And in between there, I have a student in grade 6, grade 8, grade 10, and grade 12. So we span quite a few years. We're not too far out of, the topic was parental vaccine confidence. We're not too far out of those preschool age group, but we're also into adolescent vaccines. And of course, with COVID, talking about and receiving COVID vaccines and such. So my experience with rapid reviews is very minimal. I mean, my past, I knew about reviewing the literature, but really not the methodology with systematic reviews or rapid reviews. And is it more prevalently rapid reviews? I had no idea how quickly things would be, all the steps and stuff. So that course, and as I said, I was really thankful to have it, was really all the experience that I had. I was introduced to the topic, again, from that forum, but also the researcher from NCCMT. Anyway, told me a little bit about their question and such, and again, ascertained that I wanted to be part of the review. And I was told about the timeline and through the steps, oh, you should expect to hear from me at such and such a time. And then I waited. And this is going to sound maybe a bit silly, but because I was expecting to be contacted within a certain period of days after that time passed, I'm like, what happened? Am I still doing things? And so I had questions as like, did the review start on time? Why haven't I heard anything? Am I still a partner? Should I reach out? And I do know, but not every person knows, that things can slow down in academia and sometimes deadlines aren't met. And and such. And this, so it kind of left me hanging a little bit. And so I just want to suggest that everybody really, really needs to clearly communicate. So if there is a delay, just reach out and say, hey, we're working on it. Something happened. We'll touch base with you just as soon as we're able to. So, and that talks about contingency plans. Now, in the review that I was on, there was a handing off. I got an email saying I'm no longer leading this review. I'm handing you off to somebody else, which I didn't know would happen, but it happened. And I also understand as a parent that gets very, very busy that sometimes I might have committed to this 2 to 3 week period, but something could come up. So I'm always thinking about contingency plans. It might be I might have to change like the way I interact with the researcher. It might be at a different time. It might be a different way. It also might be that, you know, hopefully maybe there's another partner on that can take over or do a little bit more work, or it's just thinking about what will you do if you're unable to complete the review and kind of having a contingency plan in place. And I was asked to identify themes and gaps. And when the switchover did happen, so that contingency plan, switching over to a new researcher, I was given a preliminary review. And this is suggesting remembering to give the partner time to review the materials. So this for me was sharing midway, and it helped me to figure out some of the themes and some of the gaps already. I'm already thinking about it rather than giving it to me at the end and saying, okay, I need a response the next day because this is such a short timeline. I really appreciate it to kind of see the review in progress and be able to start thinking around how to contextualize this and what was missing. And also I wanted to say I was fine with a virtual method of getting in contact with me, but not everybody might be. Some people might like a phone call. There may be citizens partners that actually do not have access or regular access to computers. And some people might like to be able to put their comments in text, by email and such. So we really need to be flexible there, and listening is key. I said this story last time I presented, and it was talking it was actually counseling before I got married, and it was talking about communication. And the person who was doing our counseling said, what you say is what you want to be heard. And lots of times something is lost in the middle. And so listening is key for that. And I also, to contextualize things, so I'm a parent, 6 kids. They all have a little bit of health issues. They have neurodevelopmental disorders, migraines and such. We've kind of navigated the medical system a little bit. It's been very frustrating as a parent. But I have this story from what happened last time, and it happened just the day I was presenting. And I had my 11-year-old call from school and say, Mom, and he was crying on the phone because I didn't give permission to get a vaccine at school. And he didn't understand why, and we really hadn't discussed it. So as much as I talk about communication, I do fail at communication at times. And the reality is he was trying a new med and is still trying the new med. It's the 3rd med we're trying for a particular condition. The other 2 did not suit him and had side effects. And the side effects from the vaccine and the medication, some of them can mimic one another. So we really didn't want to interfere with this test with the med. So we just have to wait on that vaccination. But what that did allow us is to actually talk more about the upcoming COVID vaccination, which is coming to our schools in January, and talk about why, you know, we're prioritizing the COVID vaccination and such. Parents have many different reasons why they would be vaccine hesitant. I've had a kid that did have troubles with vaccines and has recently as well. I also have an uncle that died before I was born, and all I knew of him was a picture that my grandparents had. He died of polio, and a sister that had lifelong lung damage from pertussis. So as somebody who's seen the benefit of vaccines, but also seen problems with them, I'm that vaccine hesitant person that can provide context. And from there, I would say to check in and finalize the review. So I received a nice email thanking me for being part of the review, and I really, really appreciate it. Thank you. And then I got this link to this final review, and I was like, And I read the review. I read the executive summary, which I really, really needed to do, and agreed with most of it, except for one sentence and really only a few words. And I had the opportunity, I really do think Maureen is being a bridge here. She was a bridge for me. I was able to reach out to her and say, well, I kind of have this bit of a problem. I don't think this is what I really meant to say. This isn't really what I meant to say, but this is what is heard. How do I deal with it? And she offered to actually reach out or suggest I reach out. And I chose to reach out, and it was fine. Everything got resolved, and then a step was put in that the finished review could be read over by the citizen partner beforehand. And lastly, I wanted to talk about acknowledging contributions. Now, the SPORE Evidence Alliance patient compensation form, it has been adopted by COVID End, which I really appreciate. As a stay-at-home caregiver who hasn't really brought any income in, you know, to me, that makes me feel like I'm appreciated, but it also makes, even just the thank yous make me feel like I'm appreciated and that I've made a difference. And so the lessons that I learned, I found that training was nice to have, and then I found I had more opportunities as for myself as part of a pool. I'm in PEI. Sometimes in Canada, it feels like it's the end of the universe where we don't see as much research happening. There is some, but it seems like a lot of places, other places in Canada have much more going on. And I don't know how I would get connected to these opportunities. Timelines are approximate, contingency plans are needed, communicate clearly and in preferred ways, a final check-in so that the citizen partner can, you know, say, oh, well, I really didn't mean to say that, or yes, absolutely, I love it. You've gotten everything I've said in there. It's good to have the support. As I said, I really do think Maureen and Francois are bridges. There's somebody that we can go to. If I didn't have them, I would have liked to have another patient partner definitely on the team, but that's not always possible. And it's nice to feel appreciated and to have a thank you, a name on the finished review. And I have to say, the reviewer or the researcher asked me if I wanted my name on the finished review. Some people will, some people won't. But I did. It made me feel like I contributed it, and I really appreciated that. And I want to thank you for giving me the opportunity to talk today. That's what I have to share.
Thank you so much for that, Amanda. It's really great to get those perspectives. And it was when we did this similar webinar about a month ago and heard those comments, we specifically right away tried to put into action making some improvements as well as we heard along the way. So it's all in progress, and really getting the feedback really helps to make improvements as well. So Mike, I'll turn it over to you now to hear your perspective of your participation in the rapid review looking at risk factors for severe COVID-19 outcomes in children under 12.
Great, thank you very much, and good morning to everyone. I want to acknowledge I'm on the traditional unceded territory of the Kwantlen First Nations and Katzie First Nations in Maple Ridge, BC. I just want to say a few things about the importance of patient engagement and citizen engagement in research. In research, everyone is trying to do the most diligent and effective research, and that's the research that reaches the most people and helps the most people. So by including patients and citizens, it helps to reach to those spots that we can't always see from maybe an academic level. I have an academic background as well, but on the ground level, often certain groups get missed because of just the way the system works. And for example, like undiagnosed children or people that don't want to share a diagnosis might be missed because they're trying to avoid stigma. And that's something that's prevalent across other categories other than just illness and health, but also in other types of discrimination. So different parts of the population are missed. And one of the things that I thought was most effective about the studies that I've been in part of with SPORE EA and the COVID end is the reciprocal engagement. So like Amanda was saying, you know, they present something to us, we make our comments on that, they review our comments, and then they make their comments and ask again, do you have anything more to add? And how can we fill this out a bit to include exactly what you're saying and get the result of better, more effective research, and research is going to reach everyone. Also, there's the importance of the quick, rapid review that has really been done well. In the study I recently did, we were looking at the children under 12, and the whole review was done very quickly, and everyone's on the same page. So it really, even that reciprocal engagement was done effectively, emails and you know, online interaction. It really helped it go smoothly, and I found what I had to say about who was reached and who was not reached with some of the goals in the research was addressed very well that way. So I think that's all I'm going to say today on that. But thank you very much for having me to speak this morning.
Thank you so much, Mike, for those comments, really helpful. And so that really is all of the presentations that we had for today. And I think this we have just a few moments left for any questions or comments.
Thanks, Maureen. I think one thing that you know, was very interesting. These presentations were great, but I think one thing that kind of comes to mind is, you know, where we go in the future. This is a really great opportunity to build that patient engagement into the research around a very focused topic. So I think it might be interesting to hear from, you know, maybe everybody just briefly in terms of, you know, how we think we can build on this for, you know, future issues as they come up in terms of engaging patients in a more comprehensive way.
Well, I might just jump in first, and I think one of the things that I didn't say in my presentation, but absolutely should have, was, you know, without having Maureen Smith and the pool to turn to be able to organize this for us really quickly, it would not have been possible. So as I said, some of these reviews were being turned around in, you know, days. And so what really made this so easy for us, and I've, you know, interacted with Maureen almost on a weekly basis for a very long time now during most of COVID. And so I know Maureen really well, and she's talked about the process and what we need to do. So, and as I've said, I don't know when Maureen sleeps, because it doesn't matter when we email her, she always responds so quickly. But, you know, we would pop her an email and say, we've been asked to do X. Can you help us identify a patient or citizen partner? And then she'd have us fill out the form. You know, after the first time, we knew the first time to connect with Maureen, we should connect with the form already filled out. And then Maureen would take that, and usually within 2 days, she had identified 1 or 2 partners for us and would connect us, and then we could take it from there. But without that, it would be very, very challenging for us to do that. And so I think moving forward, if we're thinking about this opportunity to continue responding to decision maker requests, even post-COVID or not for COVID topics, there needs to be a mechanism that facilitates researchers' ability to connect with someone they know and trust, who can then connect them to these patient and citizen partners. So from our perspective, I think that's absolutely key moving forward, that we have in place the funding and the mechanisms to do that.
Maybe I'm going to answer the not sleeping bit. That's because I don't have a real job. I'm not doing this like you're doing, adding on to your day job, then you add this on. This is actually all I'm doing. So that's why it looks like I'm not sleeping. That's a really good question, Stephen. I've been thinking a lot about this because we're actually writing all of our legacy papers now and that. And we're kind of in transition with COVID in with the new funding offer. So there's been a little bit of downtime, and I've been thinking a lot about it, like what made it work, how do you sustain it? And one of the things that Andrea and I discussed this summer, I guess, with Janet, was that our course, our mini course, we made a commitment to, adapting it for researchers. Had we offered that course in May for researchers, they wouldn't have taken it. They were busy trying to get the rapid reviews out, and we didn't think they would have 10 hours to actually do the course. The patient partners did, and they did it. So we're thinking about those kind of things. What kind of training can we offer? Kind of things like Maureen Dobbins, you've adapted the way you're presenting rapid reviews. You've got a section for what additional thing. So how do we do that after? How do we keep that going? And how do we create this? I think the reason it worked is that you had all these committed people with a very personal link. How do you replicate that? Like, where do you go from that? We tried to do some work internationally because people asked us, can you give us your forms? Without that personal link, it's very, very difficult. You need champions. So who are the champions in Canada, and how do we get them going, and how do we get that? So there is a lot of thinking going on to that. I mean, if I did all this work and it dies after COVID, I've had it. Like, this is not, I'm looking at the future, because I don't want to, I'm going to brag because I'm going to give myself the right to brag. But what we've done as far as integrating the patient citizens in those evidence synthesis is groundbreaking work. There's no doubt about it. It hasn't been done at that level before. So how do we maintain that, and how do we continue with that? I think I've been giving that a lot of thought, and I think there's lots of opportunities, and it's just that you have to do them at the right time. You have to adapt to the situation that you're in. So it was immediate. We need people right now. Let's train them. Let's get them on the ground. Let's get them going. And now let's go back and reflect on it and sustain it. Stop there.
Great.
I'd like to.
Oh, yeah, you go ahead, Amanda. I was just going to say I'm being cognizant of time, but would love to hear your thoughts, Amanda.
Well, two things. I'd like to get more knowledge about evidence synthesis into the hands of the public anyway, so that they generate an interest there. And I'd like to see a national database where we could put in our interests and our lived experience with key tags so that it can search and kind of have a match with researchers there. And it's not just for rapid reviews, but full systematic reviews anyway, because lots of people are starting research and doing a review before they, proceed into their next step, and having all of the universities, all the research institutes aware of this is a resource to make your research more impactful.
Yeah, I just gonna put in 2 cents here. I agree with that totally. And to be able to reach out to those demographics through a database would be so important, because it would reach and make all those results more helpful for everyone included.
Great. I guess I have the final word. So I agree. I think capacity building, like what Maureen Smith said, is so super important, and in particular for researchers. And also, how can we support our patient partners, and how can we move forward to more patient co-led projects? Because I think that's something really exciting. And what can we do to support that and sustain those type of opportunities? Thank you.
Great, thanks, Andrea, and thanks to all of our presenters today. It's been a very interesting webinar. I've certainly learned a lot. So thanks for taking the time to be with us today. Thanks for everybody for attending. And as I mentioned before, a recording from this webinar will be posted on the COVID-N site, and also we'll share it through Twitter as well. So people that were not able to join with us today will be able to listen to this as well. So thanks again to everybody, and we will talk to you soon.